Mrs. X, 22-year-old female, resident of Nandgaon, Baroda, wife of Mr. Y, shopkeeper by occupation, Hindu by religion, farmer, uneducated, belonging to a lower socioeconomic status, with an obstetric score of Gravida 4, Para 3, Live 2, and Abortion 1. Her LMP is 21/8/21, and her EDD is 28th May 2022. She has chief complaints of amenorrhea since 8 months with easy fatigability, breathlessness on exertion, and palpitation since 2 months. She also complains of swelling over the lower limbs since 1 week.
Yeah, Tanvi, here there is a small correction actually. See, for few examiners, it is like, see, they are already pregnant. They know that they are pregnant. So few people prefer to denote it as 8 months of gestation rather than 8 months of amenorrhea. See, if you feel that it is 8 months of amenorrhea, you know that she is pregnant, right? And you have been treating her, and like you have been giving the care also. So there is no point of stating that she is having 8 months of amenorrhea. You just put it as 8 months gestation. That would be a better thing.
Okay.
Yeah, that would make more sense than amenorrhea, because if it is a case of amenorrhea, again, you have to evaluate and all. So if it is 8 months of gestation, then it is to the point. You know that she is pregnant. You know that she is taking antenatal care. So there is no point of putting it as amenorrhea.
Okay.
Yeah.
History of present illness. Patient was apparently all right. Then she developed complaints of lethargy and developed complaints of lethargy and tiredness, increasing progressively in intensity and duration, followed by inability to continue her normal work activities. It was followed by breathlessness on exertion and palpitation, and she also had complaint of swelling over the lower limbs, which since 1 week, which decreased on rest.
Yeah. So here, why is this point very important, whether it is relieving on rest or not?
Ma'am, so that we know that it is physiological anemia of pregnancy, edema of pregnancy, or it is some pathological cause.
Yes, yes. So what are the causes for physiological edema in pregnancy?
Ma'am, physiological and edema, there is hypoproteinemia, and ma'am, there is a pooling of this thing. Basically, it is more on the right side and it disappears on rest. So mainly it is because of hypoproteinemia and hemodilution.
Yeah, mostly it is because of decreased venous return to heart because of the pressure on the inferior vena cava. So when there is change in posture, see, whatever it is, if it is hypoproteinemia or whatever it is, won't change with position as such. Okay. So just because if it is a physical, mechanical compression on the inferior vena cava, when the patient changes her position, obviously it will come down. So it is called physiological edema just because of mechanical compression of the inferior vena cava by fetus. Okay, that's the reason we ask them to lie down in left lateral position and to get up in left lateral position, so that we can avoid sudden compressions of venous return and sudden fluctuations in the venous return to the heart. Okay, and so here the patient has come to you with complaints of lethargy and tiredness, right? So what else you want? See, after taking your chief complaint, you'll be directing your history to one, or to eliminate few other causes causing the same problem, and you'll be coming to a provisional diagnosis by the end of history. So in this history of present illness, you have come to know that she is having lethargy and tiredness. So what are the points you are thinking of, and how you want to take the other parts of the history of present illness?
So ma'am, we'll have to investigate other causes as well. So if we have to find out if there's any history of chronic blood loss, or if she's having some infection, or if she's having a history of high blood pressure, which is causing the edema, or we have
and regarding the lethargy and tiredness?
Lethargy and tiredness, we have to rule out other cardiac symptoms. If she's having any other problem like orthopnea, dyspnea, and paroxysmal nocturnal dyspnea, and any.
So how you want to grade dyspnea?
Ma'am, we have NYHA classification, 4 classes of dyspnea. Ma'am,
yes, please carry on.
Ma'am, the 4th is when there is dyspnea on rest. Ma'am, 3rd is when she has got exertion. She has got dyspnea on exertion, and she's not able to carry out her daily activities.
Okay.
And ma'am, grade 3 is when she is not able to do extra work. And grade 1 is, ma'am, she's a bit breathless than normal.
Yeah. To be specific, in which category your patient will fall here?
Ma'am, she will fall in grade 3
Grade 3, she is having inability to continue her normal work
work
activity.
activities.
But see, I mean, like, she doesn't have any dyspnea on exertion also, right?
Ma'am,
Okay, she doesn't have any, I mean, like, inability to work, carry on normal activity. Yes, yes, yes. Okay, fine. Yeah, yeah. So carry on. Yeah.
Ma'am, she has no history of syncope, chest pain,
Mhm.
or paroxysmal nocturnal dyspnea. She has no history of any generalized swelling, headache, and blurring of vision. There is no history of cough with expectoration, hemoptysis, evening rise of temperature. She has no history of any leaking, bleeding PV and leaking PV. She has no history of worm infestations. She has no history of bleeding PR, any melena or hemoptysis. There is no history of
Here, see, the thing is, if you tell that it is myelina and hemoptysis, history of presenting illness should be, I mean, like, it is better to avoid medical terms, right? So this is what patient tells you. Patient will not tell that she's having melina, she's having hemoptysis and all. Okay, so you better put it in a clear words, like colloquial language, like the one, I mean, which can be understood by a patient, not by a doctor. Okay.
Okay, ma'am. So,
Yeah.
ma'am, we should put it like she's not having any history of bleeding.
She's not having any bleeding manifestations while cough, I mean, while passing stools and all. Okay, that would be a better thing.
Okay. No history of fever with chills and any burning micturition or passage of urine, blood and urine. And there
Yeah.
is no history of any discoloration of skin. Ma'am, this should
Mhm.
also be not put because she won't be able to tell them.
Yeah, yeah, yeah.
Then, ma'am, history of present pregnancy. She
Mhm.
first trimester, it was a spontaneous conception of a non-consanguineous marriage. Her
Mhm.
history, there is no history of any irregular cycles, so she's sure of the date. She was diagnosed at 1.5 months of amenorrhea by UPT.
Your voice is fluctuating, Tanvi. Can you please put it?
Sorry. Yeah, yeah. No history of any irregular cycles, hence she's sure of the date. She was diagnosed at 1.5 months of amenorrhea
So
by
how, I
UPT.
mean, how did she come to know that she is having regular cycles? How did you decide that she is having regular cycles? What did you
Uh,
ask the patient?
Ma'am, I asked her like in how many days the cycles were there, and if
Mhm.
there were, and for how, like it was. She told me that it was a 3 to 5 day cycle every 28 to 30 day. So I asked her if
Okay.
she's been missing any cycles in between, or if
Mhm.
she is having a gap of 2 to 3 months between any of the cycles since last 5 or 6 years, any recent times. So she said that no, the cycles have always been regular and that not associated with any problem of heavy bleeding or dysmenorrhea or anything.
Okay. Mhm.
Then, ma'am, she was booked at the government hospital at 2 months of gestation, and she was advised all the antenatal investigations, and they were found to be normal. The dating scan was done, which was normal, and she was advised one yellow tablet, which was not taken regularly. There is no
Okay.
history. Yes, ma'am.
Yeah,
There
yeah,
is no.
please.
There is no history of excessive nausea, vomiting, fever, or rashes, radiation exposure, drug exposure, bleeding per vaginum, discharge per vaginum, or any other burning micturition. In the second trimester, quickening was felt at 3 months. She was perceiving the fetal movements well. There were 2 doses of TT taken at 4 at 5 months, vaccinated for COVID as well. The second USG was done at 5th month and found to be normal. The lab investigations were done, which were normal. There is history of irregular intake of the tablets prescribed, that is the yellow, red, and white tablet. There was no history of any high BP recordings and no history of epigastric pain, blurred vision, headache, decreased urine output, or
So to
swelling of.
summarize what you want to highlight in second trimester and first trimester in the history. So, okay, yeah, you just tell me what you want to highlight in first and second trimester. What you think are the major things which you should not miss in a regular antenatal care?
Ma'am, first of all, ma'am, if she's sure of her period of gestation or not, like
Yes.
the dating
Why is
scan.
it important?
Ma'am, because if first of all, if the pregnancy, it is important so that we know the expected date of delivery, and also we are able to monitor the growth properly.
Yes, exactly. Correct. Okay.
So if means it should not be, if it doesn't correlate with the physical findings, then we would be in
Yes.
doubt.
Yes.
Then.
Yes.
Ma'am, also in first trimester, we need to see if she's a booked case or not, so that we know that she's been in a regular follow-up or she's been taking the medications or she's been prescribed the medications earlier or not. So
Okay.
the medicines are important. So she was started on folic acid, but she did not take it. And
Mm-hmm.
similarly, in the second trimester, whether she was regularly visiting the physician And also, ma'am, in the first trimester, the part of the non-consanguineous marriage, so chances of
Okay.
thalassemia, and ma'am, uh, ma'am,
And
any
also
history of
hyperemesis, because
yeah,
most of
any
the patients will have this nutritional deficiency starting in the first trimester itself because of the hyperemesis. Okay, because they'll be losing weight and all the nutrition required will, I mean, like the deficiency will start in the first trimester itself. Okay,
okay.
even that could lead to anemia even if they are not anemic before the pregnancy. In first trimester, any decreased intake of nutrition can also result in anemia in later part of the pregnancy, right? So
Okay.
that could also be a cause. Okay.
Okay.
Yeah.
Ma'am,
In
in the
second
second,
trimester?
ma'am, we'll ask for the vaccinations if she's taking
Okay.
all the vaccinations or not. Then
Mhm.
we'll see if any other warning signs of if she's developing any other disease, any bleeding per
Okay.
vaginum or any spotting
Mhm.
or any
Mhm.
epigastric pain and all warning signs of preeclampsia, whether we can predict whether she is a candidate for preeclampsia. Or
Mhm.
and ma'am, the scanning should be done to see if there is any the growth is proper or not.
Anomaly scan is most
And
important in second
yes, ma'am,
trimester.
anomaly scan to find out
Okay.
any congenital anomalies.
Yeah.
Uh,
Yeah. Okay.
Ma'am, also the date of we can correlate with the quickening, the
Yes. Yes.
ETB.
If we had missed our date correlation in first trimester, because most of the people will not turn up for the checkups in first trimester. Okay, they'll realize that they are pregnant after 3-4 months. By the time they'll be entering the second trimester, and the quickening is also a good thing to correlate her gestational age. Okay. Yeah. Okay, then fine. Next, and what are the lab investigations which you prefer doing in second trimester particularly?
Ma'am, we'll repeat the hemoglobin and also the
Mm-hmm.
OGTT between 24 to 28 weeks.
Yeah. So okay. So how often? So how often do you have to do the hemoglobin?
Ma'am, hemoglobin should be done at least once in, it should
So
be
what are the
done,
recommendations actually?
ma'am, once in 24, once in first trimester, then at 24 weeks, 20, 32 weeks, and then as per required.
Yes, yes. See, if she's not anemic before, if she comes to you in the very first antenatal visit after becoming pregnant, you have to run all the blood tests like hemoglobin and all. And then we have to repeat it at 24 to 28 weeks, and then again at 30, 32 weeks, and then 36 weeks. Because why? Because the first time in first trimester, the one which we do in the initial stage will tell you whether she's deficient, I mean, like she's having any deficiencies before the pregnancy or not. But as such, because of the pregnancy, all the pregnancy related changes, high hemodilution will happen in second trimester. That again will cause to decrease in HP level. So this can be diagnosed in the second screening test at around 24 to 26 weeks. Okay.
Okay.
Yeah. Okay. Okay, then fine.
Ma'am, third trimester, patient was appreciating adequate movements. There was no history of any abdominal bleeding PV and abdominal pain, bleeding PV or leaking PV. USG was done and the admission, and they reported that the fetus did not correspond to the gestational age.
Okay. So she's having IUGR also. How many weeks of gestation she is?
Uh, Ma'am, she is 36 weeks.
36 weeks. Okay. Okay, fine. Yeah.
Ma'am, obstetric history, score of gravida 4, para 3, L2A1. So para 1, 4-year-old female child, full-term normal delivery at hospital, which was uncomplicated delivery. Then para 2 was an induced abortion at 12 weeks for some congenital anomaly. Then for some anomaly, not congenital anomaly. Then para 3 was a 2-year-old male child, preterm delivery with history of blood transfusion for severe anemia, and the child was born with very low birth weight.
So, I mean, at what months of gestation she delivered?
Ma'am, she delivered at 8 months only, 9 months only.
Okay.
Oh,
Okay.
sorry, 8 months only. Sorry.
8 month. Okay. Okay. Mhm.
Then menstrual history, age of Minaki was 14 years. Her LMP was 21/8/2021.
What is the age? What is the, I mean, when was her last childbirth before this pregnancy? What is the interpregnancy interval?
Ma'am, that was 1.5 years back. 2-year-old, 2 years
Okay.
back.
What is the significance of interpregnancy interval?
Ma'am, interpregnancy interval, ma'am, if the two pregnancies are too close, then ma'am, the iron stores are not replenished, and the health of the mother is not recovered, and she's not ready for the next pregnancy. So in case of such cases where the history is already like that, we should counsel the patient to at least give a gap of 2 years between two pregnancies.
Okay. What is the ideal inter-pregnancy interval?
Ma'am, ideal should be 3 years, 3 to 4 years.
Yeah. See, it depends. See, inter-pregnancy interval is significant in two ways. First one is regarding the replenishing the stores, whatever iron stores and other nutrition stores. And the second thing is, if it is a previous LSCS, it also has to, the scar also has to heal. The scar strength is also important. So, in a way, ideal inter-pregnancy interval is 18 months.
18 months. Okay.
Yeah.
So, ma'am, past history is not significant. Family history, she has history.
Coming to menstrual history, can you please specify how many days she bled in her this thing?
Yeah. Ma'am, she was having a regular cycle of 5 to 6 days, and she was having 28 to 30 days, heavy bleeding with 5 to 6 pads per day. There was no history of any dysmenorrhea or passage of clots. She has not been investigated for any cause before.
Okay, fine.
Past history not significant. Family history of hypertension in her mother 10 years back, and she was on oral antihypertensive drugs. Personal history, sleep is adequate, bowel bladder habits are normal. There is no history of any addiction, alcohol or smoking. She belongs to middle class and there is no drug addiction.
Okay, fine. Any family history of any congenital abnormalities, because already one kid is having some congenital abnormality, and you are telling that patient has come to you with the complaint of dyspnea, and already one abortion, the previous child was terminated because of anomaly. So what should be the significant history points you have to elucidate? See, here if the patient is, if the patient is having some lethargy or whatever it is, tiredness, something with dyspnea and all, and also there is a prior history of abnormal child. Okay, congenital anomaly.
Heart diseases.
Yes. So your history should cover both what are the causes that could lead to anemia in this case, and also what are the other causes of dyspnea, like heart diseases and all, right? So in your family history, it is better to code that, right? Whether the other family members are having any other congenital anomalies or not. Always, see, it is not like negative history should not be taken all the time, but few points should be elucidated. Few points should be evaluated whether they're there or not. It is significant mentioning that point, right?
Ma'am, any particular we have to ask apart from congenital heart diseases in case of anemia and congenital anemia?
No, in case of particular anemia, only sickle, any family history of sickle cell disease. But neither, you can't quote that she's having no family history of sickle cell disease. But as such, no familial inheritable diseases you can quote.
Okay. Ma'am, then dietary history, she has mixed diet, and this was by 24-hour recall method. She consumes around 1300 to 1500 kilocalorie per day with 33 grams of protein daily.
That's way too less, right? So what is the daily calorie requirement for a pregnant lady?
Ma'am, protein requirement is again 1.5 to 2 grams.
Not protein, the total calorie also.
Ma'am, ma'am, it should be around 2600 kilocalorie per day.
Yeah, it depends on the activity level of the patient. Again, is there any specific increased requirement in pregnancy?
Yes, ma'am. The pregnancy, usually the calorie requirement is increased, and we require around extra. Ma'am, iron requirements are raised by 30 grams per day. Usually, it is 10 grams per day.
30 grams per day? Is it that high? What is the typical iron requirement for non-pregnant lady?
Ma'am, 10.
10 what?
Ma'am, usually 1 gram per kg per day.
Yes, 1 gram per day, not kg. 1 gram per day is the normal iron requirement for non-pregnant lady. Why? Because there is epithelial loss. It is to account the loss of iron from the body. Okay. Yes, for a menstruating lady, because they'll be having menstruation and all, you have to add another 0.8 gram per day iron requirement. But for pregnant lady, what are the iron requirements? In first trimester, second trimester, and third trimester? Hello?
Ma'am, in menstruating women, it is around 18 milligram per day. And in pregnant women, it is around 40 milligram per day. Like in the first trimester, we require 1 to 2 grams per day. In second trimester, 4 to 5. And in third trimester, 6 to 7.
There are two schools of thoughts actually. According to WHO, it is 1 mg per day in first trimester, and second trimester it is again 4 to 5, and in third it is 6 to 8. But for particularly if you see any Foxy recommendations and all, it increases to 10 in second and third trimester. Okay, because Indian women are actually like they are in more need of iron, because our diet itself is iron deficient diet. That's the reason. Okay. Yeah. So what is the total iron requirement in pregnancy?
Ma'am, total iron requirement is around 40 milligram per day.
No, how will, let's see, what does Mother and Family Health Welfare recommends for a pregnant lady as an iron prophylaxis?
Ma'am, for iron prophylaxis, we are usually given 60 milligram of elemental iron plus 500 microgram of folic acid.
See, is 60 milligram recommended by Mother and Health Family Welfare?
Ma'am, elemental iron, ma'am, latest.
What is WHO recommendation?
Ma'am, 100. Earlier it was 100 milligram elemental iron.
Okay.
But now, according to the Anemia Bharat, they are asking for 60 milligram elemental iron.
See, how much of it will get absorbed?
Ma'am, only 10% will get absorbed.
Yeah. See, if your iron requirement is somewhere around 6 to 8, so for suppose if she takes 100 mg of iron, out of that 10% will be absorbed, accounting for 10 mg per day. That is requirement, right? Yes, so what happened, according to Ministry of Family Welfare, they have to take 100 mg for 100 days. Okay, so which accounts for 10,000 in total pregnancy after first trimester. So in this 10,000, 10% is absorbed. So that means a total iron requirement in whole pregnancy is 1000 mg, right? So in total pregnancy. Why? Because 500 mg is needed for the mother's RBC production and all, and 350 to 300 mg for fetal RBC and placental tissue. And to compensate the blood loss during delivery, it takes almost another 250 mg. And whatever gain we have because of not having menstruation is somewhere around 150 to 200 mg. So when you calculate everything, it will come to somewhere around 1000 to 1100 mg. Okay, in total pregnancy. Okay. So pregnant woman needs 1000 mg extra iron in her whole pregnancy. Okay. So to combat the deficiency, you have to supplement her with 10,000 mg iron, out of which only 10% will be absorbed. Yes. Okay. So that's the reason Ministry of Health and Family Welfare recommends 100 mg elemental iron for 100 days after 14 to 16 weeks. Okay. Which has to be continued 3 months postpartum also. And along with that, it also recommends 500 micrograms of folic acid per day. Okay. But WHO recommendations are little different. WHO recommends 60 mg elemental iron and along with 400 micrograms of folic acid. That is a daily dose. Okay. They didn't specify whether to start in first trimester, but generally we don't start it in first trimester. So you can start in second trimester, and it also has to be continued 3 months postpartum. Okay. It is as simple as it is. Like WHO recommends 60 mg of elemental iron per day, and Ministry of Family and Health Welfare recommends 100 mg of elemental iron per day. And if there is any deficiency, they can double the dose. That means 200 mg would be the dose. Okay. And according to WHO, if therapeutic iron requirement is 120 mg, prophylactic iron requirement is only 60 mg. Yes, ma'am. Okay. No confusion now?
No, ma'am.
Yeah. Okay. Okay. Fine. Yeah. Carry on.
So, ma'am, general examination, the patient is sitting comfortable. She is conscious, oriented with time, person, and place. She has a poor build and looks malnourished. General condition is poor. Her height is 152 and her BMI is around 16.
So, do you think her BMI is adequate?
Not really, ma'am.
Okay.
At least 18 to 19 should be considered normal. 19. Above 19 will be. Then, ma'am, pre-pregnancy weight was 44 and present pregnancy weight is around 53.
So why is pre-pregnancy weight important?
Ma'am, we need to check for the weight gain. In normal pregnancy, usually the weight gain is around 10 to 11 kgs. And there is a gain like and if the weight gain is not, if weight gain is more than 1 kg per week, we need to, if the weight gain is more than, we need to check for preeclampsia, signs of preeclampsia. If there's
is it a specific criteria for diagnosing diagnosing the preeclampsia? No, weight gain is
it's not a specific criteria for diagnosing it, but
it is just used for the monitoring purpose, not for the diagnostic purpose. Okay, yes. Just because she is gaining weight, you can't diagnose her to be a preeclamptic, but you can, once if she is diagnosed with preeclampsia and she's having more weight gain, at least 0.5 to 1 kg per week, then you can tell that the symptoms are getting worsened. Okay, but you can't tell that just because she is gaining more than 0.5 to 1 kg per week, she is having preeclampsia. So it is not used for diagnostic purpose. It is just used for management purpose. Okay. And one more main part for main thing where we can use pre-pregnancy weight is to formula. It can be used in calculating the iron dose requirement for intravenous iron. What is the formula for iron dose requirement calculation?
Ma'am, we need, it is the Gansen's formula. So we use 2.2 into hemoglobin deficit into the birth weight in kgs plus 1000.
It is 2.4 according to Foxy, 2.4 into HB deficit into
weight, body weight in kgs.
What weight you put there? Is it pre-pregnancy weight or is that current pregnancy weight?
Ma'am, current pregnancy weight.
No, the formula actually calculates according to the pre-pregnancy weight.
Okay.
So iron deficiency formula has to be calculated specifically according to pre-pregnancy weight. Added to that, you are adding 1000 mg of again iron to just replenish the stores. Few people will add only 500, but according to Indian guidelines, according to Foxy and all, you have to add 1000 mg. So coming all together, the formula is 2.4 into HB deficit into pre-pregnancy weight plus 1000 mg of iron. Okay, yeah. So that is the importance of pre-pregnancy weight.
Okay. Ma'am, hydration is adequate. She's febrile on touch. Pulse is 84 beats per minute in right radial artery with good volume, normal character, no radiofemoral delay. All the peripheral pulses are palpable. BP is 122/80 in right arm in supine position repeated after 15 minutes, and similar findings are there in the left arm. The respiratory rate is 18 per minute.
So why is it important? Why is it important to repeat? And when was the first BP reading taken?
Ma'am, it was taken when she came. She was asked to rest for 10-15 minutes.
So what? Yeah, what are the things you will note before taking BP? What are the prerequisites of taking BP in a pregnant lady?
Ma'am, she should not be anxious, first of all.
Okay.
Then the cup should be of the adequate size. That it should be like, if she's too obese, a cup more than 30 centimeters should be taken. And ma'am, it should be taken both in supine position and in the sitting position. And,
yeah, in sitting position, what and all you have to say?
Ma'am, in sitting position, the
back should be leaning. Back should be supported by some other, like she should be sitting in a chair where her back is supported and her feet should touch the ground.
Okay, ma'am.
Okay. If she is in supine position, then there is no worry. Obviously, her back will be supported. But if she is sitting, her back should be supported and her feet should be touching ground. Okay. And at what level you will measure the BP?
Ma'am, at the level of the heart, we have to keep the manometer. And we'll first take by the auscultatory method, and then by the palpatory method, and then by the.
And after how many minutes of putting the position, you have to take BP? See, if you ask the patient to sit or some supine or whatever it is, and you will take the BP immediately.
Ma'am, the patient gets comfortable maybe around up to 2 minutes.
Yeah, after 15 to 20 minutes of maintaining the same posture, you have to take BP. Okay, this is actually, we feel that it is theoretical, but in practical, if you do it in practically, obviously you can find the difference. If the patient comes and walks to you in the OPD, if you check BP, it will be different. And if you ask her to rest for 15-20 minutes, and if you take the BP again, it will be different. Okay, so first and foremost, she should be in the lying or supine position or sitting position with back rested and feet touching the ground. And she should maintain the same posture for 15 to 20 minutes at least. Whatever it is, she should be comfortable for 15 to 20 minutes, and then you have to take the BP.
Okay.
Yeah. Okay. This is very important, particularly in cases of preeclampsia.
Okay.
Okay, you can't, most of the times you will be diagnosing her to be having high BP and all, but when you repeat the BP in good posture after giving good support and all, it will be different. Okay. Yeah.
Ma'am, normal hair texture, orodental hygiene is fair, pallor is present, bilateral pedal edema is present, no clubbing or no ectasis.
So you have mentioned about bilateral pedal edema. Is it pitting or non-pitting?
Ma'am, non-pitting.
Okay. Is it non-pitting?
Yes, ma'am.
So how do you see pitting or non-pitting?
Ma'am, 2 centimeters above the medial malleolus, we'll press for like 5 to 10 seconds. And
30 seconds. Yes.
30 seconds.
And then leave and study it after 30 seconds.
Okay.
Okay. Yeah.
Yes,
so what are the causes of pitting edema and what are the causes of non-pitting edema? Because you said your patient is having pedal edema, right?
Causes of pitting and non-pitting edema. Ma'am, in cases of chronic kidney disease, congestive cardiac failure, the type is usually pitting edema. And the generalized edema or anasarca is non-pitting edema.
Why?
Because it is due to the raised intravascular volume.
Yeah. See, in generalized anasarca also, if there is any fluid retention or if there is any, like if the heart is not, if there is any impending heart failure or whatever it is, renal disease or whatever it is, if it is just because of hypervolemia or decreased venous return, it will be always pitting edema. If there is any protein accumulation, like some cases of filariasis kind of thing, there, even if you give pressure also, the the edema will not go off. So there you have to, there it will be non-pitting edema. So most of the cases of anemia and cardiac failure, you have pitting edema, not non-pitting edema. Okay? Yeah.
Ma'am, pallor is present, bilateral pitting edema, no clubbing, no icterus. The skin is pale. Nail ridges are present and no palpable lymph nodes. Spine is normal. Bilaterally, breast appear to be normal. Systemic examination, ma'am, the respiratory system air entry is bilaterally equal. There are no additional sounds heard. Cardiovascular system, apex feet in the fourth intercostal place and anterior axillary line. S1, S2 is normal. There are no murmurs heard. Central venous pressure, no sensory or motor deficit. All reflexes are normal.
Okay.
Obstetric examination, ma'am, on inspection, the abdomen is uniformly distended. Uterine ovoid is in longitudinal axis. All the quadrants move well with respiration. Umbilicus is central and inverted. Linea nigra and stria gravidarum are seen, and there are no dilated veins. On palpation, all the findings of inspection are confirmed. The local temperature is not raised. SFH is 28 centimeter, AG is 80 centimeter, and her uterus measures around 30 week size. Relaxed.
So what is the importance of symphysis of fundal height? How do you measure?
Ma'am, symphysis fundal height is important so that we can correlate up till from 24 to 32 weeks. It relates well with the period of gestation. Yes. Also, ma'am, it will be raised in multifetal pregnancy and in cases of edema, and it is reduced in cases of IUGR. So it gives us a rough idea about the condition of the baby inside the fundal.
What is the fundal height? Fundal height corresponding to? Where is the fundal height here? You just measured. Okay, uterus measures 36. Okay, fine. So she's, her fundal height is corresponding to her gestation, not corresponding, right? She's 36 weeks gestation and her fundal height is only 30 weeks.
Yes, ma'am.
Okay, so what do you
Ma'am, she's
infer from this?
32 weeks. She's 32 weeks of gestation, not 36 weeks.
Okay, so she's 32 weeks of gestation with fundal height of 30 weeks.
30 weeks.
So what does it infer?
Ma'am, a gap of 2 weeks. So usually we take a gap of more than 4 weeks to be significant in cases
for
of
IUGR. So here, do you feel that she is having IUGR?
Ma'am, it could be, but it could be more confirmatory on the USG because just a gap of 2 weeks does not indicate much. It could be some other factors.
Okay, fine. Yeah.
The patient is relaxed, longitudinal lie, fetus cephalic presentation. Uterus is relaxed, non-tender, and the liquor is adequate. On auscultation, FHS on the right spino-umbilical line. It is regular, 142 beats per minute. The per speculum examination and per vaginal examination was not done.
Okay.
So, ma'am, summary is 22-year female with an obstetric score of G4 gravida 4 para 4 life 2 A1 with history of anemia and blood transfusion in previous pregnancy with a previous preterm birth with a period of gestation of 32 weeks 5 days with singleton live fetus in longitudinal lie cephalic presentation and not in labor with pallor and pedal edema with complaints of fatigue and breathlessness on exertion and swellings over the legs.
Okay. So what is the provisional diagnosis for your case?
22-year female, gravida 2 para 1 live 1, gravida 4 para 3 live 2 A1 with 32 weeks 5 days gestation with tiredness, palpitation, breathlessness on exertion with pedal edema with pallor with live singleton pregnancy and cephalic presentation suggestive of features of anemia.
So why do you think that this is a case of anemia first? What are the points suggesting towards anemia in this particular case? Why can't you think that it could be a cardiac disease?
Ma'am, because she's not complaining of other cardiac problems like
what are the other
ma'am, orthopnea, paroxysmal dyspnea, any Krebs or any other problem, ma'am, related to cardiac disease. Or
do you think that it could be? Do you think that she could manifest in other ways if she's having any other heart problems? What are the things you want to eliminate? See, you just tell me what are the points here pointing towards anemia and what are the points here not pointing towards cardiac disease?
Okay, pointing towards anemia. So, ma'am, the complaint of tiredness.
First, you have to start with her socioeconomic status. She belongs to
a low socioeconomic status.
And next is her gravida. She's a multi-gravida. Okay.
Yes.
Obviously, they are under high risk for iron deficiency anemia. And here itself, you can rule out telling that her previous 2 pregnancies were uneventful in view of cardiac disease. If she had any cardiac disease, they could be evident in
presented earlier.
Okay, so that is the way you can rule out cardiac disease. Just not because just because she's not having any other symptoms, you can't tell that she's not a case of cardiac disease. Had it been primary, she could have had equal chances of having anemia and also cardiac disease if she is having this grade 3 dyspnea. Okay. So here she is a multi-gravida and other points. She is also having, she's thin built and her BMI is low, her nutritional status is low. And yes. And what are the other things pointing towards anemia here in this case?
Ma'am, her occupation could be considered because she is a farmer, so she is exposed to poor working conditions. Apart from that, ma'am, she has history of a preterm birth and there are repeated pregnancies in lesser interval of time. And there's also history of abortion, early abortion. And
and she had irregular intake of medicines.
Irregular intake of medications.
Yeah. So that's the reason you might point toward, you might come to a diagnosis of anemia, provisional diagnosis, not conclusive diagnosis. Okay. So for definitive diagnosis, how will you evaluate this case further?
Ma'am, first, ma'am, we'll send all the routine antenatal investigations, but specifically
what are the routine antenatal investigations you send?
Okay, ma'am.
You should not tell routine antenatal investigations because for few people sending CBC itself is routine. For few people sending other blood test is also routine. You have to be specific all the time. Okay.
So for this case, ma'am, we will send for her complete blood count, hemoglobin, hematocrit, red cell indices, and peripheral smear.
Yeah. Can you please tell me what and all what are the significance? What is the significance of each and everything?
Ma'am, Ma'am, if we first we have to rule out the grade of ma'am for any patient of if we are suspecting anemia, we need to see for the type of anemia, for the grade of anemia, and then for the cause of anemia.
First is
So,
diagnosis of anemia. How will you
diagnosis.
diagnose that she's anemic?
Ma'am, first of all, the hemoglobin itself will indicate whether she is anemic or not.
What is the
So,
diagnostic criteria for anemia according to
ma'am, for
WHO
WHO, it
and
is less
according to
than 10.
ICD?
Ma'am, according to WHO, it is less than 10 milligram per
Mhm.
deciliter in our country, and otherwise it is taken as 11 milligram. And
It varies according to trimester. In first
yes,
trimester, what is the thing? And second trimester and third trimester.
ma'am, first trimester is taken as 11, second 10.5, and then again 10.5.
10. Why? Why in first trimester it is 11, and in second and third trimester it is again 10.5.
Ma'am,
Why
because of
it
the
can be 10.5
requirement,
for all the trimesters?
ma'am, because of the requirement, because the requirement in the first trimester is quite low, so even a mild change in hemoglobin should indicate that it is anemia.
No, that's the other way around. Actually, the thing is, she'll be having physiological hemodilution.
Okay.
Okay. When will the physiological hemodilution start? It starts in first trimester, but it peaks in second and it plateaus in third trimester at around 30 weeks. Okay. So actual physiological changes, hemodynamic changes starts actually in second trimester. That's when she will go into hemodilution. So just because her HB has dropped to 10, 10.5, or what is the physiological, you just tell me what is physiological anemia, then you can have a clear picture of this. What is physiological anemia and what is pathological anemia?
Ma'am, physiological anemia occurs because there's increase in the plasma volume in pregnancy, normally by 30 to 40%, and in RBCs it is only 10 to 15%.
Yes.
So comparatively, the rise in volume is much more. So there is a hemodilution in the.
How much HB you can expect to fall?
Ma'am, it should not fall below 11 in the first trimester.
No, physiological anemia, maximum the difference could be 0.5 to 1. Okay, maximum is 1, but generally we take it 0.5. Just because she'll be having physiological anemia, we have decreased that normal range from 11 to 10.5. Okay. Because it could be physiological also. That 0.5 drop change in HB is physiological. So that's the reason the limit is 11 in first trimester and 10.5 in second trimester. Okay. And how do you grade embryo? So first you have got to know that she's having anemia by just looking your HB level. So how do you grade her anemia?
So ma'am, anemia can be graded as mild, moderate, severe. Mild would be considered as around 10 to 10.9. Moderate will be 7 to 10.9, and severe would be less than 7.
So what is mild?
Mild is around 10 to 10.9.
10.9. Yes. Okay. And we have another category called very severe in an ICMR classification.
Which is less than 4.
Less than? Yes, 4. Yeah. Okay. So you have graded the anemia and you have known that you came to know that patient is having anemia. So how will you evaluate further? So what are the causes you want to evaluate and what are the causes of anemia and how you want to evaluate her further?
So ma'am, the causes could be hereditary causes or it could be some acquired causes. So most commonly, first we look out for nutritional anemias as they are very common in our country. So for looking out for iron deficiency, folic acid, vitamin B12 and other deficiencies. Then
so what percentage of anemia is because of iron deficiency in India?
Ma'am, 80%.
Yeah, 70 to 80%. So prevalence of iron deficiency in anemic cases is almost 70 to 80%. Okay. So that's the reason we look more into nutritional anemia first rather than looking for other causes. Okay. So, okay, then fine. How will you evaluate her for further to know the cause of anemia?
Of serum iron.
Hello.
Then
you do serum iron for all?
Ma'am, only if it is, ma'am, if we are suspecting iron deficiency anemia.
So when will you suspect iron deficiency?
We'll go. Okay, ma'am. First, we'll see the red cell indices, MCV, MCH, MCH.
So, which is the most important red cell indices in deciding how you want to evaluate?
Ma'am, MCV would be important.
Yeah, why?
Ma'am, because it comes down earliest.
This is the one which helps in differentiating. See, it can be microcytic or macrocytic, right? If it is less than 80 femtoliters, it could be a microcytic anemia. If it is more than 100, depending on lab to lab, variation will be there regarding the upper limit. If it is more than 100, generally it could be macrocytic. So iron deficiency anemia will not be macrocytic, right? So that itself will help you to find the cause, whether it is microcytic or macrocytic. Always label your anemia, whether it is microcytic, normocytic, or macrocytic. That itself will tell you in which way you have to investigate further. For suppose you have done a simple hemogram and you got to know that she is having low HP and you got to know that she is having microcytic anemia, how you want to go further?
So, ma'am, if we know the microcytic anemia, we'll rule out all the causes of microcytic hypochromic anemia.
Okay, what are the causes?
Iron deficiency anemia. Then we have thalassemia. Then there are cases of lead poisoning. Then sideroblastic anemia or anemia due to any chronic diseases.
Yeah, okay. So you have got to know that she's having iron deficiency. I mean, like microcytic anemia. So how you want to differentiate further between iron deficiency and thalassemia?
We'll see the RDW, that is the red cell distribution width. And, and also, ma'am, in thalassemia, these iron stores will not be depleted. And
so what are the tests you want to do further? So it should go on in a particular flow, right? First you have diagnosed, you have graded, you got to know the cause. What are the, I mean, like it could be a microcytic or macrocytic. Now you want to know what are the causes causing this microcytic anemia. So how you want to differentiate iron deficiency from thalassemia? In which test you are going to differentiate by doing?
Ma'am, we'll do the Nestrov test for thalassemia.
So you want to do a Nestrov for all the patients? Imagine the patient has come to you.
No. First we'll look at the iron and the ferritin levels. Ma'am, if the iron and ferritin levels are low, we'll consider iron deficiency anemia.
So you are doing iron and serum ferritin for all?
Ma'am, if you're suspecting iron deficiency anemia, they are more confirmatory.
See, here the thing is, your patient has come to you, you have diagnosed she's having microcytic. Just do serum ferritin. The other tests are very costly. And even WHO doesn't recommend all other tests, whatever transferrin saturation, TIBC, serum iron, all these are very costly. Okay, you can't burden the patient by doing all these tests. Just a simple serum ferritin will tell you whether the iron stores are depleted or not, or whether she's having iron deficiency anemia or not. Why? Because if you're having a microcytic anemic patient, you can't just give iron to all, because for suppose if it is a thalassemic patient, you are giving iron overload. You're doing iron overload. Okay, so it is must to rule out thalassemia and iron deficiency. Okay, so that's the reason before checking, it is always advisable to go according to protocols. Protocols always suggest doing serum ferritin to know and to diagnose iron deficiency. Okay, so it is like it should be in a flow, in a proper way. First you diagnose, you grade the anemia, and you know whether it is microcytic or macrocytic. Then you do simple serum ferritin. By doing the simple serum ferritin, we'll come to know whether it is iron deficiency or not iron deficiency. For suppose in few cases it could be normocytic also. Why? Because most common cause of anemia in India is nutritional anemia rather than iron deficiency anemia. What do you mean by nutritional anemia? It has both, iron deficiency, vitamin B12 deficiency, folic acid deficiency, everything will be there. So just because you're treating with iron and all, it can't, the HB cannot be normalized. It has to be treated by giving folic acid and vitamin B12 also. So that's the reason, rather than going through MCV and all, you better do a simple serum ferritin. You'll come to know whether she's having iron deficiency. And if it is microcytic, it is clear-cut iron deficiency. If it is normocytic, or if you find any macrocytic picture also, then you have to supplement her with vitamin B12 and folic acid. If it is a clear-cut case of microcytic with lesser serum ferritin, then you can give only iron supplementation. Okay. So what is the cutoff level for serum ferritin?
Ma'am, for serum ferritin, we usually take the level to be less than 15. The normal value is around 15 to 200. But if it is less than 15, we consider it to be low.
Yeah. So according to WHO 2022, it has released one guidelines regarding how to use serum ferritin. Okay, you can just go through it. If it is less than 15, obviously it's a clear-cut case of iron deficiency. If it is less than 30, it shows that iron stores are depleted. Okay, it need not manifest as an anemia, but still the iron stores are depleted and soon she may land up in anemia. Okay.
Okay,
In
ma'am.
few cases where there is inflammation, or if she's having any fever or whatever infection or inflammation, obviously serum ferritin is a inflammatory marker also, right? It will be raised. Okay, then it may not be diagnostic. So if the patient is having any infection or inflammation, any serum ferritin levels less than 70 is considered as anemia. Okay, if there is associated infection and if you check the serum ferritin levels.
Okay.
And any serum ferritin levels more than 150 to 200 is considered as iron overload. Okay, this is the recent WHO guidelines regarding serum ferritin. We just go through it. It is a beautiful paper. Okay.
Okay, ma'am.
Yeah. Okay, son. Okay, then fine. Okay, you have got to know that she is having iron deficiency. So what to do? How you could have prevented the situation? What you mention first?
Ma'am, sorry. What?
So
Hello.
you have diagnosed your patient to be having iron deficiency. Hello, am I audible?
Yes, ma'am. Now you're audible.
Yeah. So yeah, you have diagnosed her to be having iron deficiency, right? So how you could have prevented this?
Could have prevented this, ma'am.
Yeah.
Ma'am, ma'am, in the first ma'am, a good nutritional counseling of the patient, that she should take high iron content and high protein food, and also, ma'am, if she had a history of anemia in the previous pregnancy, so ma'am, before pregnancy, she could have been administered iron folic acid, and to keep a normal level, and also ask her to prevent pregnancy till her anemic profile is normal or not.
Yeah, pre-pregnancy normalization of iron, I mean, like HB should be done because already she had a history of previous blood transfusion and all, right? So better we should have we could have prevented this before pregnancy itself. Okay.
Yes,
and now okay, she's having iron deficiency. What is her HB? Do you have her investigations with you?
No, ma'am, I don't have her investigations.
Okay, fine. So how will you manage her now? You came to know that she's having clear-cut iron deficiency anemia. So how are you going to manage her?
Ma'am, since she's only 32 weeks, so still, and it is not, if it is not very severe anemia, it depends upon the gestation age as well, and also the severity of anemia. So, ma'am, if it is very severe anemia, we will try at 32 weeks of gestation. If it is very severe anemia, we will directly go for blood transfusion. However, if it is severe anemia and she's at 32 weeks, we can give her parental iron preparations as well, and oral to be continued. Ma'am, because oral.
So you continue both oral and IV parenteral also?
No, ma'am, we stop the oral 24 hours before the parenteral preparation because it leads to
Why?
saturation of the receptors and the effect does not come properly. Therefore, we stop it.
Along with saturation, the major important factor is causing anaphylactic reactions. Okay. If you first, I mean, like few people tell that it is because your receptors are saturated and all, but still the major cause, important cause why we don't advise oral and IV, I mean, like parenteral iron together is because of the risk of anaphylactic reaction. Okay. Yeah. So what are the, I mean, where you will give oral iron, where you will give parenteral iron? You tell me that.
Ma'am, in mild anemia, oral iron is sufficient in any period of in first trimester. And ma'am,
first trimester, okay.
Ma'am, in severe anemia, ma'am, after 32 weeks, if it is very severe anemia, and if she is presenting with signs of cardiac failure, then blood transfusion is better rather than going for the oral and the iron parental iron. And ma'am, if she is already 36 weeks, we can directly go for blood transfusion. And ma'am, parental iron can be considered between 30 to 36 weeks. See, I'll just tell you the logic behind this. Okay, whatever it is, iron or oral, I mean, like parental or oral iron, it takes 4 weeks for the HB to raise. I mean, like it starts from 2 to 3 weeks, but still to raise by at least 1 gram, it takes 4 weeks, right? So there is no point of giving a oral or parental iron just because, I mean, like just before delivery. If for suppose if she's going to deliver at 40 weeks, there is no point of giving iron supplementations after 36 weeks, right? Because it takes some time to build up, and you are not targeting her delivery time. It may come to normal after her pregnancy, after her delivery. So after 36 weeks, if you find after 36 we'll tell, but generally according to Fox recommendation, it is after 34 weeks. So after 34 weeks, the indication for first I'll tell when to do blood transfusion, then I'll tell about oral and parenteral iron.
So if it is after 34 weeks and the HB is less than 7, irrespective of whether she's having cardiac failure or heart failure, impending heart failure, you have to transfuse her, because we don't have any time to build her HB just by oral or parenteral iron. Okay, so that is one main indication. Before 34 weeks, even if she has severe anemia, I mean, like if it is more than, if it is less than 7 and between 5 to 7, in case if it is between 5 to 7, if she is having any impending heart failure, then only you have to give blood transfusion. If it is less than 5, even if she is not having any impending heart failure, you have to transfuse. Okay, that is the scenario before 34 weeks. After 34 weeks, any HB less than 7, you have to give blood transfusion. So there ends the story for blood transfusion. Coming to oral and parenteral iron. Oral iron, actually recommended dose is 200 mg of elemental iron per day for therapeutic purpose, because for prophylactic purpose you are giving 100 mg, because 10% of it will be absorbed. That means 10 mg will be absorbed per day, which is a normal requirement. Okay, but here the patient is having anemia, so you have to double the dose. So if you give 200 mg elemental iron, 10% of it, that means 20 mg will be absorbed. So that is therapeutic dose. Okay, so this oral iron is preferred in all mild cases. Okay, may it be first trimester, second or third trimester. Okay, except in few cases, like if she has undergone any bypass surgery, or this bariatric surgery where iron is not absorbed, or if she is having any severe gastrointestinal symptoms, or if she is not adherent to the treatment, then we can transfer it, we can change it to IV iron, even though it is mild anemia, because she is not taking orally, she's not tolerating orally, then you have to go to parenteral iron. So parenteral iron, again here, the main contraindication for parenteral iron is it should not be given in first trimester.
Yes.
And main other thing is your oral iron should be stopped 24 hours before starting parenteral iron. And there should not be any history of anaphylaxis previously. Okay, because parenteral iron preparations are generally prone to cause anaphylaxis and all, right? And you know how to calculate the dose, I've already told. And what are the iron preparations you know? You just tell me what are the oral iron preparations you know, and what are the parenteral iron preparations you know.
So ma'am, oral iron preparation, the most commonly that we use is ferrous sulfate, which is 200 milligram containing 60 milligram of elemental iron. Ma'am, it has good bioavailability and it is also very cheap. Then ma'am, the other we have is ferrous fumarate, which has 100 milligram elemental iron. Then we have ferrous gluconate, which has 30 milligram of elemental iron. And we have ferrous ascorbate. In ferrous ascorbate, it has very good content, but then ma'am, it is very costly, so usually we don't.
Yeah, so ferrous sulfate is the cheapest alternative you have, but it has severe gastrointestinal symptoms. Okay, but it is most commonly used because of its affordability. Okay. And ferrous ascorbate has lesser gastrointestinal side effects, and it is little costly, but it has better oral tolerability. Okay, and ferrous gluconate and all has they also have lesser GI symptoms, but they are very costly and high doses are needed, because the percentage of elemental iron in the prepared salt is very less for ferrous gluconate. That how much percentage of elemental iron will be there, you have to know everything about this. Ferrous fumarate has 33% and ferrous ascorbate has 20%. Okay, how much percentage of elemental iron is going in your preparation? For suppose if you take 300 mg of ferrous sulfate, some 60 depends on what kind of ferrous sulfate it is. If it is ferrous sulfate dehydrated form, then every 200 mg of ferrous sulfate will have 65 mg of elemental iron. So that should target for preventive therapy. If you have to take therapeutic dose, then you have to double the dose. Okay, yes. Targeting 120 mg per day. And coming to iron, parenteral iron preparations, you have iron dextran, iron sucrose, and the recent one, ferric carboxymaltose, FCM. So iron dextran is absolute nobody is using because of its own side effects, like having anaphylactic and test dose is needed, and IM preparation is very painful and all. Okay, and IV is totally contraindicated. It won't be given in IV form. Iron sucrose, what are the disadvantages with iron sucrose?
Ma'am, again, the chances of anaphylaxis are high. And
so test dose is needed?
Ma'am, yes.
What is the recommendation? So for iron sucrose, there is no need of test dose because as such anaphylactic reactions are lesser when compared to aldosterone. You can tell it is minimal, not zero, but it is very minimal. Okay, so that's the reason we don't give test dose generally. But for practical approach, we can give test dose. And for few patients where they have already history of allergies, it is better to give test dose always. Okay. And what about ferric carboxymaltose?
Ma'am, it is not it is not considered to be. It is not approved to give antepartum.
Yeah, it is not approved to be given. I mean, like to give in the antenatal period, but it is given in postnatal period. RMC you can give in postnatal period, and it doesn't have any anaphylactic reactions as such. And a single dose can increase your HP by 1 gram at least. Okay. Yes. Yeah. And what else you want to discuss? I think we can wind up the session. If you have any doubts, just let me know.
Ma'am, can you talk about the management of patient in labor?
Sure. Yeah. Yeah. So how do you manage anemic case in the labor?
So ma'am, we have to first put the patient on oxygen. We have to arrange the blood beforehand.
Always preserve the blood, yes.
Keep the patient in propped up position. And
why?
Ma'am, so that the venous return is not too much towards the heart. So the heart.
So what is the main logic of managing the second, I mean, like delivery second stage labor or whatever it is?
Ma'am, so that there is no extreme maternal distress, there is no cardiac overload, and patient is able to deliver comfortably.
See, the main thing is your venous return suddenly increases after delivery. Why? Because uterus will be contracting and retracting, and almost your your volume increases, venous return increases by 80%. So that itself, as such, the second stage of labor itself is very, it creates a lot of burden on your heart. And immediately after the delivery also, again, whole blood is squeezed out of the uterus, and again, the venous return increases. So as such, because of anemia, there will be a risk for heart failure. And whoever is in the labor, again, the risk of heart failure is increased. So you have to minimize the time she's in labor. Okay. So that's the reason we want to shorten the second stage. Okay. We should not stress the mother. It should be shortened. How can you shorten the second stage of labor?
Ma'am, by forceps delivery.
Yeah, forceps delivery. So if you feel that it is getting prolonged, it is always better to shorten the second stage of labor. And how do you manage postpartum?
So ma'am, postpartum, we'll continue the.
And in first stage, you have many. In other first stage of labor, also you have to be vigilant about the intake, IV fluids and all.
IV fluid intake.
Yeah, and you have to ask her to ambulate, and there are many points. I think we are running out of time. We can discuss it in some other class. But major, logic behind this is you should decrease the risk of heart failure in second stage and first stage of labor. Okay, and in immediate postpartum also. And after the delivery,
when the anemia needs to be corrected, and she should take the iron therapy for at least 3 months. And also, ma'am, contraceptive counseling needs to be done, and we need to counsel her that the spacing should be at least 18 months to 2 years.
Yeah. And how will you check? How will you manage postpartum anemia? And how will you diagnose? So what is the level?
Ma'am, it is again 11 grams.
Okay, good.
Ma'am, management will again be we'll continue with the 160 milligram.
First, you have to diagnose it, right? Whether she's having any postpartum anemia, even if she doesn't have any antenatal anemia, you have to diagnose, because all pregnant women are under risk for postpartum anemia also. So you have to ask them to do one HP test after 2 weeks of delivery. Okay. And then you can diagnose postpartum anemia, and then you can treat her accordingly. Okay. Yeah, according to guidelines, according to WHO and the Minister of Family Health Welfare, you have to continue iron and folic acid supplementation for at least 3 months. Yes. Okay, prophylactic dose.
One doubt I have, ma'am, in the indications of blood transfusion, it is said that if there is very severe anemia, that is less than 7 grams, we need to give the patient we need to give the patient blood transfusion even during labor. So, ma'am, in labor, since we are restricting the fluid, will we give the blood when she is in labor?
Actually? See, where did you read this guideline?
Ma'am, in the indications for blood transfusion only, when is to be given.
So actually, as such, by FOXY, there is no indication for blood transfusion in labor. Okay, but nevertheless, there are few cases where patient has collapsed immediately after the delivery with HB of 5 to 7 also. That we could have managed before delivery only. Of course, patient can come to you in delivery also. Then you have to do strict vigilant monitoring and you have to manage, and then postpartum only you can give blood transfusion.
Okay, ma'am.
As such, I don't find any guidelines telling you have to transfuse blood in delivery, but I'll check that and I'll let you know.